Hello everyone, we might make a start. So welcome to what I believe is now the fifth ADNeT Memory Clinic webinar. You should be able to see my screen now, but this is about clinical quality registrars, improving the quality of care across Australia for people living with dementia and mild cognitive impairments. We've got two great speakers lined up today, so it should be a very interesting and relevant webinar. Just a reminder that a recording of this will be available after the event, along with all the other previous webinars on our YouTube channel, and the address is on your screen now. My name is Matt Paradise. I'm an old age psychiatrist and also a senior research fellow working with the ADNeT Memory Clinic initiative. I'd like to first do the acknowledgements of country. So the Australian Dementia Network acknowledges the traditional custodians of country throughout Australia and their continuing connection to land, sea and community. We pay our respects to all Aboriginal and Torres Strait Islander peoples, their cultures, and to their elders past, present and emerging. So for those of you who may be joining us for the first time, I might spend a moment just to explain what ADNeT actually is. So ADNeT is the Australian Dementia Network, and it's a collaboration of 15 institutions across Australia. It was started a couple of years ago on a 5-year NHMRC and NIDR grant, really to bring together and collaborate Australia's dementia research experts. It has three main arms: the ADNeT Clinical Quality Dementia Registry, which we'll be hearing a lot more about from our speakers today, so I probably don't need to mention that. And then the Memory Clinics arm, of which I'm a part of. And really the idea of that is to establish a network of memory clinics to try and harmonise standards of assessment and importantly also post-diagnostic care. And we'll be doing that through guidelines, rolling out a range of tools to help clinicians such as neuropsych norming tools, and we'll also be developing peer support programs. And the final important initiative is ADNeT Screening and Trials. And the aim of this is to develop a standing, highly characterised trial-ready cohort of individuals, either people at risk or those with MCI or dementia. The idea being to kind of speed up the acceleration of new diagnostics or therapeutics. And underlying that, there's ADNeT Tech and ADNeT Business to try and ensure the financial sustainability of the initiative. So we're keen for people to get involved as much as possible. Again, Dr. Ward will be talking about the ADNeT Registry and how you can be involved in that. But also we're keen for people to join the list of national memory clinics and services. So this isn't just for memory clinics, it's really for anyone who does specialised cognitive assessments as well. And the idea being that it will be publicly visible, it is publicly visible, and it'll facilitate linkages. It'll be available for patients, for primary care and for specialists to see what other services are on offer. If you'd like to be involved in that, we've now got over 100 clinics and specialists involved. We can ask you to complete the short online questionnaire, and then we can host the service. And actually, I'm very happy to say that in the last few weeks, we've put this on our website, which is available for everyone to see. As a searchable Google map, you'll see the over 100 clinics and services around Australia. In terms of just some basic housekeeping, everyone on the webinars comes on muted. If there's any technical difficulties, press the raise hand button, and Joe, our moderator, will try and help you out. Please ask Q&As, so you can either do that as the speakers are talking, or you can do it in a 10-minute Q&A at the end. You can post anonymously if you prefer to do this, or have it listed under your name. And then afterwards, you'll be asked to complete an optional survey, and then a certificate will be emailed out to you later. We are keen on getting valuable feedback to improve the quality of these presentations, but also if there are any particular topics you'd like to see in the next few months and years. So What everyone's actually really interested in are today's speakers. So initially we have Dr. Stephanie Ward. She's a staff specialist in geriatric medicine at Prince of Wales Hospital here in Sydney. She's also a senior research fellow at the Centre for Healthy Brain Ageing, CHIBA, at the University of New South Wales. Her research interests are in the prevention of dementia and especially in the quality of care for people living with dementia. She's the clinical lead for the ADNeT Clinical Quality Registry, as well as a co-investigator on the Intergeneration Integration Initiative that is establishing and evaluating intergenerational preschools that involve community-dwelling older adults. She's also an investigator on a number of clinical trials funded by the NHMRC, investigating interventions to reduce dementia risk. Dr. Monica Cations is an epidemiologist who has worked in the ageing and dementia field for over a decade. She is a research fellow in the College of Education, Psychology and Social Work at Flinders University, supported by a Hospital Research Foundation Early Career Fellowship and NHMRC MRFF Emerging Leadership Investigators Grant. She also holds partnership status with the Registry of Senior Australians, ROSA, which I believe she'll be talking about in more detail, at the South Australian Health and Medical Research Institute. So in terms of the order of proceedings, Stephanie's going to talk for 20 minutes, Monica's going to talk for 20 minutes, and then we're going to have about 10 minutes afterwards for Q&A. So very much looking forward to hearing the speakers now.
So thank you so much, Matt, and to Johannes for inviting me to give this talk today about the Australian Dementia Network Clinical Quality Registry. And it's wonderful to be giving a talk about this today, and also to be co-presenting with one of our heroes, which is Dr. Monica Cations, doing fantastic work with the Registry of Older South Australians that she'll talk to us about. And thanks everybody that's joined in. I'm just going to get rid of my own picture here. So I'd like to start off with some acknowledgements, and firstly to the NHMRC that has funded the Australian Dementia Network Initiative, and to philanthropic partners Wicking and Yugglebar, to members of the ADNeT Registry Steering Committee, and I think I saw that some might be online as well. We have a really dynamic, committed steering committee who've provided a lot of fantastic strategic oversight. These slides are a little bit outdated because we welcomed 2 new members last week, a consumer and a carer, which has been fantastic. To the ADNeT investigators, ADNeT grant led by Professor Chris Rowe, and Professor Susanna Ahern is the academic lead of the registry. We have a really fantastic national ADNeT registry project team under the leadership of Casey Wallace, and we have senior research fellow Xiaoping Ling, but a really wonderful group of state coordinators who are trying to roll this program out nationally and really work around the clock. Unfortunately, I've spelled Xiaoping's last name wrong, sorry. And I'd also like to acknowledge the input and the help we've had to date from people with lived experience of dementia and mild cognitive impairment, as well as caregivers who have helped and continue to help us shape this initiative, especially by giving feedback on a lot of documents and processes involved in the registry. And also thanks to Dementia Australia, who've helped coordinate a lot of that work. And a special special thanks to clinicians who've been involved in talking to us, giving us feedback, or participating in the registry today, giving us really good feedback, because registries are about helping people who live with a particular condition, and helping people by ensuring that clinicians get the information they need to ensure that what they're doing is really what they should be doing. We've already had a bit of an overview about ADNeT and all the organisations involved across Australia. So I'll start off by saying what is a clinical quality registry? Some of you might be familiar with this, but often when I use the word, or when we talk about a registry or a registry for people living with dementia, I think a few different ideas come to people's heads, because there are different forms that registries or registers can take. For example, there are registries that exist for the primary purpose of research into perhaps risk factors or progression of a disease. There are registries of people set up to monitor and surveil prevalence or incidence of the disease, and so these exist particularly for things like cancer, but there are some epidemiological registries that exist for dementia in different jurisdictions. And sometimes you can have volunteer registries. For example, a great example of a particular type of register is the Step Up for Dementia initiative, or also the ADNeT Volunteer Portal initiative, where people who are interested in being matched to research opportunities can register their details. Another example of this is the Joint Dementia Research Initiative in the UK. So a clinical quality registry is a database which has a specific purpose and specific features. It involves a systematic collection of data for people within a defined clinical domain, which means people with a particular clinical condition or a clinical event. And primarily the collection of data is around evaluating the appropriateness and the effectiveness of care. The data is primarily used to benchmark practice and to highlight variations in practice and variations in outcomes. Because when you have data like this, when you have access to data like this is how you improve what you're doing at the clinical interface. And I noticed before, but Johannes, when he was giving an introduction, he mentioned that at the end of this talk, you can give feedback about this talk, and that's all about making sure the next talk is, better. We're all used to giving feedback often, or being asked to give feedback about different aspects of our lives these days, and we collect that type of data to make things better. And certainly in the clinical setting, in a hospital, for example, hospitals do collect certain types of data to try and improve and monitor their performance, and that's required for accreditation and for monitoring. But clinical quality registries can extend that, particularly for conditions that are particular conditions. And so there are a number of clinical quality registries that operate in Australia and operate in different clinical conditions. I work at UNSW, where one of my colleagues in my department is Professor Jackie Close, a geriatrician, and she's the co-chair of the Hip Fracture Registry, which is a clinical quality registry for everyone that's had a hip fracture, which is really, really helpful for hospitals to ensure they're delivering the best possible care that they can. So how do registries work? How does a clinical quality registry actually work? Well people with a particular condition, people are entered into the registry, usually by clinicians, and at what's called a minimum data set. I've abbreviated it to MDS on the slide, is entered into a secure database. And data that's entered in this way can be analysed and used to look at things like those variations in practice and also some quality indicators. What's also good about a registry is when you can follow people up to look at outcomes over the longer term. And it's particularly important to look at outcomes from the perspective of patients and people living with the condition, often using things like patient-reported outcomes or care-reported outcomes. Outcomes that are collected clinically, so clinical data is important, and so is perhaps data linkage, and we'll hear a bit more about the role of data linkage in monitoring quality of care from Monica's talk. So what's really important with registries is the reporting of quality and the ability then to promote practice change. And if we were to think about what would we want to monitor, what we want to measure in the setting of dementia, there's a lot of sort of what I'd call processes of care, things we do that we could measure, such as what do we do in terms of investigations at time of diagnosis, what supports and opportunities do we offer people after diagnosis, what medications do we use, what's access to services. But we're probably also interested in outcomes for people living with mild cognitive impairment and dementia, such as measures of cognition, function, any neuropsychiatric symptoms and mood changes, whether there are health issues such as falls, unintended hospitalizations, requirement for residential care, as well as other really important things like social health, quality of life, ability to be independent, and the well-being of carers. And registries sit in this really nice cycle of quality improvement, because when you have data that can reflect back on your quality, that's when you can initiate changes to improve the care that you're giving. And clinical quality registries also have other really nice features, because it is a collection of data. So this data can be accessed for research purposes. And a great example of this is the Swedish Dementia Registry, which is a very big registry, a clinical quality registry for people with dementia in Sweden, which is primarily around monitoring and driving improvements in quality. But the large amount of data really does open up important opportunities for research. So they've conducted a number of analyses of their data set that have had some number of really important findings, such as longer term outcomes from use of cholinesterase inhibitors, such as disparities in access and outcomes for people living in different areas of the country. Registries can also be a great way, or a more efficient way, of matching people to clinical trials if they're interested. Registries can be a good source of epidemiological data once they become big enough. And they can be particularly useful if there are ever new medications that come onto the market, in terms of monitoring uptake and monitoring longer term outcomes. So why should there be a clinical quality registry in dementia? Well, there's certainly been a growing momentum towards this. So in 2016, the Australian Commission on Safety and Quality in Healthcare identified dementia as a priority 1 for a clinical quality registry. And that's because it is common, because this was a perception, and we didn't have systematic data on this, but a perception in variations in care, and it's a significant diagnosis for people. This fits in a larger strategy because there is interest in clinical quality registries at a federal level and at a state government level too, because when clinical quality registries improve care, then that ultimately it's cost effective, so hospitals and health providers like this, and it drives improvements. And the recent publication of the AIHW's Dementia Data Gaps and Opportunities paper actually highlighted there are some gaps in dementia data in Australia that we know about, and that a clinical quality registry can help to start to close some of those gaps, particularly when we're helping with data around the diagnosis stage. And why else? Why would you be part of this if you were a clinician? Well, it's useful as part of your service planning. It's a way of auditing what you're doing. And some clinical services already do this. They perhaps keep their own database and monitor it. But the good thing about a registry is that you can access your own data at any time, but you can compare your own data then to the aggregate level at a national level. So you can actually see if what you're doing, how it compares. Which I think is really, it's important as a service provider to understand, what's your wait time like? Do you do things a bit differently? Are you seeing a different group of people? We don't have a great way of comparing that at the moment. Data from registries, I think I mentioned this before, it belongs to the clinical sites that enter that data, but it's a great infrastructure that can facilitate additional, perhaps local research projects. And participating in audit and review of practice can be used for continuing practice development, for CME points, for the RACP if you're a physician. And so if you engage well with a registry, it's a way of reviewing your practice. Another thing that can be nice about a clinical quality registry, and I get this feedback from clinicians, and I've heard this from the Swedish doctors as well, is that when you have to fill out a certain amount of data about people that you've seen, it can be a really nice checklist. It's just a little subtle, nudge in the right direction. Oh, I needed to ask about that, or oh, I should have checked on that. It's not the primary purpose, but it is a nice way of perhaps making sure that we are asking it and checking on everything that we need to. And another thing is that registries can, really speed up those opportunities for participation in research if people are interested, and that's something we're hoping to build with this registry. And as I mentioned before, if there are new medications, registries can have a really helpful role in terms of monitoring, when they're being used and what the outcomes are. What are the downsides? Well, there's a requirement to enter a little bit of data. and that needs to be integrated into your workflows. If you're going to, some people and some of our sites are trying to integrate it into their existing EMR. So there are some local IT processes to negotiate, although our team's helped a few sites with that. And there's a need for local governance approval as well, although our team takes care of most of that. And I'll say that I'm a geriatrician, so I work in a memory clinic in Sydney. Our clinic's been participating in the registry for nearly a year. And I think we've found it a fairly feasible, and it's worked okay in our clinical setting. And in fact, in a way, I think it's I've had a couple of people that used to work in our service that have gone off to work elsewhere now that have wanted to rejoin the registry, which I think is fairly good sign, because it can't be too bad if you've had past experience from it before and you're keen to be part of it again. So I mentioned before about we've talked before about the ADNeT initiative. And I just wanted to reiterate how the registry sits in terms of the broad initiative. And as I mentioned, registries are really great at measuring variations, benchmarking and feedback. But we hope that this works with the memory clinics in terms of measuring any change that comes about from the guidelines that are coming about. And the registry might be able to assist with recruitment into the ADNeT Screens and Trials initiative that Chris Rose presented about before at this meeting. And if and when new medications are available in Australia, as I mentioned, it's really important for monitoring uptake and outcomes. So our registry works by the clinical sites identifying who needs to be in the registry, entering that into either a REDCap database or filling out a form and somebody else enters it for you. That data is kept, it's analysed, it's kept securely, and longitudinal data then is measured either by the registry sending out patient and care reported measures, or with data linkage, or by the follow-up collection of clinical data. And that data is reported back to consumers, to providers, and to policymakers. And the data can also be accessed by third parties under a data access policy in a de-identified form for approved research studies. And this is all looked after by a steering committee. So what we do at the moment is we recruit clinical sites. So memory clinics are involved, but we've also had a few private specialists participate to date and show interest in being part of this. But other relevant outpatients like general geriatric clinics are also suitable. We're yet to recruit from general practice and acute care settings, but down the track that would be useful as well. We assist in obtaining local governance. We ask clinicians at the time of confirming a diagnosis of either MCI or to dementia to enter the patient into the registry. And we enter a brief amount of data, which I find takes me about 2 or 3 minutes on a paper form to do. And if I was to enter it directly into a REDCap, it would take a little bit longer. Some of our clinical sites do this in the context of a case conference or at the time they see the patient. And so we collect a certain amount of data that we'd be happy to share the data set with people that are interested at the end of this talk. And we have modified that on a couple of occasions in response to feedback and really helpful input from our participating sites. And then after you enter the data, the registry will send out some information to the patient, or if the patient may not have the capacity, to the person responsible, give information about how to opt out of the registry if they're uncomfortable with this. The registry sends out some patient feedback measures to both patient and to carer. And I'm very grateful to the fantastic work of Xiaoping Lin. She's led a wonderful working group which has involved people living with dementia and caregivers to give us really helpful feedback on this. And over the longer term, we're interested in collecting longer term outcomes. We have, I'll just through, so where we're up to at the moment is we've identified potentially 400 patients to be part of the registry. About 2/3 of those are on the registry, about 14 or 12 or 13% have opted out, and the remainder on a holding database in the stage of recruitment from 17 sites across Australia. 28 sites have governance in progress. There's certainly been an upkick this year in terms of participation in the registry. This map shows the sites that are currently contributing data or are about to contribute data, but we've also had engagement from a number of sites nationally and some initial discussions. So this map is only the beginning, we hope. And so far, I'll just flick through this, just examples of some of the data that you can get from the registry that you can download at any time for your own patient group. And at the moment, the median age of our cohort is 78 years, 52% are female, 70% of people in the registry have dementia, and the Alzheimer's disease subtype is a component in 84%. And we've got some baseline quality indicators that we can't read too much into at this stage, but some of the data suggests that, for example, only 47% of people are seen within 30 days of a referral to a service, and about 72% of people with Alzheimer's disease are prescribed a cholinesterase inhibitor. So we're finalising our clinical follow-up data set at the moment. We're continuing to work on longitudinal patient and care reported measures, and we're really excited about the work we're doing at the Registry of Older South Australians about the ways that administrative data linkage can be used to measure meaningful outcomes for people living with dementia, and potentially could be another entry portal into the registry. So I'm going to finish there. If there's interest in the registry, I'm happy to be contacted, as is our program manager, our wonderful program manager. And then I might just stop sharing for the moment and hand over to Monica.
Yes, thank you everyone for joining us today, and thank you Stephanie and the ADNeT team for having me today as part of this webinar. I'm really looking forward to telling you a bit about the Registry of Senior Australians and how ROSA and ADNeT can work together to, I guess, contribute to this effort of monitoring care, quality and safety in Australia for people with dementia. So, I'm certainly preaching to the converted, I'm sure, and the Royal Commission into Aged Care Quality and Safety highlighted very well that the quality and safety of dementia care has a very important impact on quality of life and symptom progression and mortality and all sorts of other things for people living with dementia and their family members. But of course, monitoring the quality of that care is very difficult, as Stephanie has sort of explained very well in detail. Dementia care is delivered in a very large variety of contexts by many, many different professionals. Unfortunately, our aged care system suffers from a bit of a lack of transparency in terms of what is going on within aged care services and dementia care services. And so unless providers kind of offer this information to you, it can be quite difficult to know what's happening. And the other thing that's important is that many people with dementia, our diagnosis of dementia in this country is not perfect. We still have not reached high levels of diagnosis, and many people living with dementia are not actually diagnosed until they reach an aged care service, and often that's residential aged care, which of course is quite late in their disease path. So while the ADNeT registry is getting up and running and improving that situation, there's this sort of missed opportunity to monitor people early in their disease course. And so what I'm going to talk about today is how routinely collected linked data can contribute to this effort. So, as you may know, there are vast amounts of data that are collected about each and every one of us as we move through using health and aged care services. And these are held by data custodians, including the Australian Institute of Health and Welfare and other custodians. And these can be used to contribute to dementia care monitoring. So there's lots of different data sources that are out there, including assessments for aged care eligibility. So that is a RAS assessment, a regional assessment for community services, community aged care services, and ACAT assessments, which are eligibility assessments for aged care services. Also assessments for residential aged care funding. The ACFI instrument can be used and has important data. Healthcare service use is collected. Pharmaceutical use, anything that we receive a rebate for, is collected. The National Death Index collects our date and cause of death. There's data available about hospitalisations and emergency department presentations, and all sorts of other data that can be accessed. And so that's the role of the Registry of Senior Australians. That is to bring many of these data sources together for the purpose of care monitoring. So the Registry of Senior Australians is a clinical quality registry that brings together data from the National Death Index, pharmaceutical use, Medicare, aged care use, hospitalisation data, and so on. And we have two components to this registry. We have a prospective cohort, which is of South Australians only, people who are registered or who are enrolled at the point of ACAT, of an aged care assessment, and who are followed prospectively. And then we also have a very large historical retrospective cohort, which is de-identified with all of this data in there. And the registry can be used for a large range of different purposes, one of which I'll talk about today. So within ROSA, it's possible to identify people living with dementia. We can identify them via aged care assessment data. Aged care assessors are required to note down people's medical diagnoses, and dementia can be one of those. Within the aged care funding instrument, it is the same, and also there's cognitive screening data within the aged care funding instrument. And also we can use pharmaceutical data to identify people with dementia, because some pharmaceuticals are only used for the treatment of Alzheimer's disease. When they are used, we can use that data to recognise when a person has dementia. And we have done some work to identify that around about 47% of the estimated incident cases per year can be identified in administrative data, within this administrative data. And currently, or in our capture that we did this study we were able to capture approximately 40% of the estimated prevalent cases within Australia that are estimated by the Australian Institute of Health and Welfare to have dementia in Australia. So that's a pretty large chunk of people living with dementia in this country. So the ROSA outcome monitoring system is an important part of what I'm going to talk about today. So the OMS is a monitoring and benchmarking system that has been developed using ROSA data, using all that linked data. We have developed 12 quality and safety indicators so far, including things like falls, chronic opioid use, weight loss and malnutrition, and a range of other indicators that we can now monitor. We can monitor for performance over time and across geographic regions. And the real beauty of this data is that we can provide it to aged care providers to learn of their own performance relative to other people or other providers, and then direct resources towards indicators that need the most quality improvement. And so this kind of forms the basis of what we're doing with our dementia cohort. So I'm just going to give you a quick sort of example of some early work that we've done using this data, where we included all non-Indigenous Australians aged 65 and over who accessed an aged care service between 2011 and 2016. And this has recently been published. Okay. So what we did with this study was we included 4 quality indicators for dementia care. So the first one was antipsychotic medication use. And the reason for that was, as many of you would know, is that these medications are quite commonly used despite serious side effects and limited efficacy. Cholinesterase inhibitor and memantine use, because these drugs, a trial of these drugs is recommended for all people with Alzheimer's disease in the clinical practice guidelines for dementia care in Australia. High sedative load, we were interested to see whether, or the rate of people being prescribed or dispensed sedative medications, because we know that people with dementia are highly susceptible to adverse drug events associated with these drugs. And also dementia and delirium related hospitalisations, because these can indicate preventable complications of dementia care. And so what you can see is that we had nearly 400,000 people with dementia within our catchment here in that 5-year period who access aged care services and could be identified with dementia in our data. And of course, a good spread geographically and socioeconomically. And basically the sort of basic message of what we found is that performance on these indicators really has not changed very much over time. And this is despite a really intensive effort to improve performance on these indicators, particularly sedative medication use and antipsychotic use, that really those efforts seem to be insufficient at actually improving performance over time. And that's also true once you account for how long people spend in our cohort in a given year. What we're also able to do with this data is map the variation in performance. And so these are called funnel plots, what you see in front of you here. And so each blue dot represents a local area, like a local government area. Along the bottom axis is the number of people living with dementia within our cohort in the area. And on the y-axis, the vertical axis, is the percentage of people in that area who've been dispensed an antipsychotic medication in that year, in the year that we're looking at here. And in the middle there, that's the average. So we know that the average, on average, just over 30% of people in each area are being dispensed an antipsychotic. And so you can see in these funnel plots that the dots are quite tightly bunched together, which tells us that there's quite a similar performance everywhere in all local government areas across Australia. And so that tells us that, you know, performance on this, the rates of antipsychotic medication dispensing and high sedative medication load are pretty poor all over the country, no matter where you live. But if we look at some of our other indicators, particularly cholinesterase inhibitor and memantine use, the dots are quite sparsely bunched, they're quite spread out, which tells us that there's very large variation in performance on this indicator. Whether you are prescribed one of these drugs really depends on where you live and the prescribing culture where you live. And that's very important because it can allow policymakers and funders to direct efforts and quality improvement efforts to where they're really needed the most. And so we can do this for a whole range of other indicators, and Tracy Eyre, who now works with ROSA, has been doing a lot of work with developing other indicators so we can monitor this over time. So this is falls-related hospitalisations. This one is unplanned hospital admissions, which can indicate potentially preventable complications of dementia care, and again, quite a wide variation geographically here. But of course, this data is limited in very important ways. So we're only able to capture here people who've used aged care, which is about a third of people with dementia, and also only those diagnosed with dementia. That's very important, and why ADNeT, you know, that is just incredibly important with improving rates of diagnosis. Most of the people in our cohort enter, although everybody enters an aged care assessment, but most enter at entry to residential aged care, which is quite late in the disease path often. So with linked data, we're less able to monitor early clinical care. We're also unable to stratify by dementia type. And we also, you know, we have quite a good breadth of data here, but what we don't have is a good depth of data. We don't have information about the indication for the medications, you know, why they were used, why the person was hospitalised and how appropriate that was. And so we lack that kind of information. And we also need more timely updates to our data linkage. It can take a very long time to get updated data. This data, of course, is de-identified, which means that it's less transparent, and the general public isn't able to kind of look at these data and know which providers are doing better than others or which areas are better than others. But the government can do that kind of behind the scenes and re-identify things. And the other important thing is the data we currently have does not include Aboriginal and Torres Strait Islander people because of ethics and governance reasons, but we're working on that, and there's a really exciting project happening at ROSA at the moment to make sure that Aboriginal and Torres Strait Islander people are included in this data. And so, you know, what we can tell from this is that the quality on these indicators hasn't really changed much over our time period, and that we can use this data to tell us that new organisational policy and regulatory measures are required. And so using data that's already there, it's already out there and available, so by linking it, this can facilitate care quality and safety monitoring at a national level without having to go out and collect any more data. And so if we're able to link it in with ADNeT, which as Stephanie said is the plan, that can facilitate care monitoring from diagnosis right through to death. with less data collection burden on clinicians and on aged care providers. We're also able here to capture people who are not formally diagnosed until they reach an aged care assessment, which is at the moment quite a good chunk of people. Hopefully that number will reduce as ADNeT it grows and grows. And most importantly, individual facilities and providers can use this information to benchmark themselves and direct quality improvement efforts in the most effective ways. So I'm going to stop talking there, but I just want to say thank you to Associate Professor Maria and ACO in particular, but all of the ROSA team and the ADNeT team for supporting this work.
Thank you both for very clear presentations, actually. That was great and just shows the capacity that we're already collecting such important information and what we might be able to do with that data. So we'll just give people a few minutes. If you've got any questions, and there's a couple of questions that have come up already, please write them in the Q&A, and also maybe just note who you'd like them to be directed to, or to both panelists. But I might use my chair's prerogative to ask a couple of questions. Starting with you, Stephanie, you probably ran out of time a little bit, but you alluded to the fact that already it's early data, but there may be some interesting information already about the baseline characteristics. I wonder if you could expand on that.
Yeah, so, and I think that's one of the really nice things. Like, I was so excited the day that I decided to download the data for my clinic, because you're there every week, you're seeing people, you get a sense about who comes to your clinic, but it's sort of interesting when you just get it all at one go and you think, oh, this is the cohort that comes to my clinic. So we've got data about, you know, for example, the number of medications that people are on, and you can see that polypharmacy is quite a bit of an issue for cohort coming into clinic. We look at, you know, what proportion have had a fall in the last year, some functional measures, and we're also collecting cognitive scores as well. So we collect MMSE, MOCA score, RUDAS score, and the KICKR score as well. And so that's really nice. I don't have a mean score to give you by dementia or MCI, but that's really nice to actually see, oh, okay, we're seeing people at an earlier stage, or perhaps we're seeing people who are coming to us at a more, you know, moderate stage of cognitive impairment. We collect whether people are driving, and we collect basic information about, you know, did you do certain tests. So we've got some, you know, preliminary information at the moment about, you know, sort of metrics of quality. I'm particularly interested in waitlist, because there's such a demand for dementia diagnostic services. And it's really nice for me to be able to say, oh, you know, maybe we need to change how we do things. Maybe we need more resources. I mean, there's nothing more powerful than saying we've got a long wait list. We need to actually improve capacity here. But I think that's a really lovely thing about a registry, because you get a feel about things, but until you actually collect data and look at it systematically, it's, you know, that's an objective way of understanding the people that you're caring for and the quality of service that you're providing. Does that answer your question?
Yeah, it does. Thank you. So we've got a question from Jane Thompson. I don't know if you can see this on your screen. How does the 12 to 13% opt-out percentage compare with other similar registries, and how might this be reduced?
Really great question. And the answer to that is it is higher than most clinical quality registries. So taking a couple of steps back, the Australian Commission on Quality and Safety in Healthcare recommends that for clinical quality registries, you opt out rather than be consented in. And that's because the registries are around measuring healthcare and quality. And if you use an opt-in, often you tend to lose data on people who are at risk of poorer outcomes. So that's why it's recommended. I think it's around 75% of clinical quality registries in Australia use an opt-out. And generally the opt-out rates are often very low, you know, in the sort of 1, 2, 3% range. So 10 to 12%, it is higher than most clinical quality registries, but I would say that, yes, it's early days and we have looked at ways to perhaps address that. So some of it was something we addressed early on in the registry in terms of how clinicians talk about the registry to patients to make sure it's clear. And we've also revised, and we're really grateful for actually the input of some people living with dementia and caregivers. We've revised we've revised and tried to simplify and make clearer the documents that come out to people, that give people the option to opt out. So it's really clear what the registry is about. But I think that given that, you know, it's not a typical registry, it's new, it can be sensitive for people. It's not unexpected, and I don't think it's too problematic, but we're early stages, and so we are, you know, trying to make sure that our documents that we send people are as clear as possible.
Thank you. And Monica, can you hear me okay? So Michael Woodward asked the question. I think this was probably some early data that you presented, saying 52% of females seems a little low, and asking for any thoughts about that. I think that was your data, Monica.
I think it was Stephanie's.
Oh, okay. Sorry.
Yeah, I think it was mine. I would say, yeah, look, it is early data. But I will say that I worked in a memory clinic before in Melbourne. And one day we did an audit of people that we diagnosed, who we saw in the memory clinic, and compared it to people that we saw out in the community with community home visiting geriatrician. And often people were triaged for the geriatrician at home if perhaps there were more functional limitations, more complex circumstances, or more advanced cognitive impairment. And I think from recollection, there was certainly a lower proportion of females that were coming into the clinic and a higher proportion we were seeing at home. And I understand why you're asking that question, Michael, because we know that, you know, we would expect it to be a higher proportion of women. It may, I think it is too early to read anything into it, but it might be that, I don't know what other people's experience of clinics are, but it might be that, you know, wives are bringing in their husbands because they're very, I don't know, I don't want to make any judgment about that actually at this point, but it is an interesting observation.
Thank you. Monica, I had a question about the data you presented on cholinesterase inhibitor memantine use, which, as you said, shows greater variability than some of the other metrics. I know we're just speculating. Any idea why that should be the case, or that in particular shows kind of greater heterogeneity?
Yeah, and there's certainly research that tells us that attitudes towards these medications among prescribers really varies quite a lot. And of course, these medications don't work for all the people who try them, and they do come with side effects. So, you know, it's not so surprising, I guess, that when, you know, if we're not seeing the benefit, if a prescriber's not seeing a benefit, that they may deprescribe quite quickly. But also we know that the culture, I suppose the medical culture or prescribing culture around you affects the way that you prescribe. You know, how your mentor or your supervisor prescribes, that can affect the way that you prescribe. And so it makes sense that behaviour clusters in geographical areas, and that can affect the variation between different regions.
Another question came up in the Q&A. In light of the Aged Care Quality and Safety Commission, are there any specific variables focusing on indicators of nursing care that can be captured or are captured by ROSA?
Yeah, that's a great question. So we don't have, within ROSA, we don't have, you know, patient-reported outcome measures or, I guess, measures of clinical behaviour, I suppose. But what we do have are indicators that can tell us something about the quality of nursing care, particularly in residential aged care, which is, you know, often nurse-led type care. And so those kind of indicators are things like pressure injuries, falls, unplanned hospitalisations, and dementia-related hospitalisations are often related to delirium and behaviour management. So, you know, those can be important indicators of nursing care. And also we know from quite extensive research now that the primary drivers of sedative medication prescribing and antipsychotic medication prescribing in residential aged care are nursing staff. And so, you know, that's another important indicator of nursing behaviour as well.
Great, thank you. Monica, you kind of made, or you alluded to the point, but you presented that interesting graph figure showing that actually not much has changed, I think, from 2010, 2011 till 2016. And you kind of said that it can be difficult to get up-to-date data, but are you kind of working with a 5-year lag, or it's just you haven't, yeah?
Yeah, we are, and that's a really unfortunate, I guess, artifact of data linkage, that it is very slow, and that was very heavily criticised in the Royal Commission into Aged Care Quality and Safety, the fact that our data is not being linked and updated often enough. And so, yeah, we are currently working with that lag, and we are expecting to get updated data up to 2020, I believe, very soon, which is but yeah, that's a big limitation of this data, and certainly something that I think the Australian Institute of Health and Welfare and other data custodians are aware of that problem, and are working to try and get on top of it.
Okay. And then a question for both of you. So I'm sure there are lots of researchers who are participants in this webinar. How can they potentially access data both in ROSA and the ADNeT Clinical Quality Registry?
Well, so in ROSA, we have a process of proposals that we're very, very happy to kind of partner and work with other researchers with this data, but we do have to obviously vet those requests, and so that all of that information can be accessed on the ROSA website, which you can find through Google. So and they come through our director and can work together to support people to develop proposals and ideas.
So for the ADNeT registry, so at the moment we're not having access to the data in this pilot phase. It is very early phase. We do have a third-party data access policy which has been developed through the data custodian held at Monash University in line with other clinical quality registries. And in general, a proposal would need to be approved by the steering committee. Data that is released is usually, we would expect, would be de-identified.
Okay.
But as I think I mentioned before, as a clinician, you can access your own data at any point for your clinical site. Yeah.
Okay.
And can I just add as well, sorry, that I realised in my earlier answer as I was talking about the lag with our retrospective data, I should have also mentioned that we do also have our prospective cohort, which we're enrolling prospectively. So, and that, that the goal is that will be national eventually. And so that won't have that problem.
Okay. Fantastic. Okay, were there any other questions from the Q&A?
I saw that there was one that I tried to answer privately, but it went off the screen. But it was a question about there's scope for regional and country geriatric clinics and private clinics to be part of the ADNeT registry. And the answer to that is absolutely yes. I realise that our map of Australia didn't quite capture the dispersion of the current pilot sites. So they are dispersed both metropolitan but also regional centres, and we have some private clinics on board already. And in fact, we've had quite a bit of interest from private clinicians, and I think it's a nice way of being connected to something and being able to review your practice, which is a lot easier when you're in a big public system and harder when you're out in private. So the answer to that is absolutely, and I think I answered privately to put my email address there. We would love to hear from anyone at a clinical site that might wish to join, both private, regional. Absolutely, we would talk through what's involved, and we've got a really wonderful team that work very hard to support sites to get on board at the moment.
Wonderful. Well, thank you again, Stephanie and Monica. They were great talks, really interesting, and I think we all got a lot out of them. So as I mentioned at the beginning, there will be a survey that comes up asking for some feedback on this. And as I mentioned, any suggestions for future topics, that would be great. And then you'll get certificates for attendance sent out by email if you provide your email on the last page. The next webinars in a couple of months, it should be very good, by Sharon Naismith, who co-directs the Memory Clinic Initiative. Along with Prof. Simon Lewis, who also works at University of Sydney Brain and Mind, talking about sleep disturbance in dementia. So that's likely at this stage to be on August the 26th, but we'll send you details nearer the time. And then all the contact details are on the ADNeT website. So certainly, as Stephanie was saying, please get in contact if there's any questions about signing up to the registry, but also if you're running a memory clinic service or a service that's assessing cognitive impairment, we'd love to have you join the list of services that are online, or just if you can share information so we can have more people involved in the network generally and having access to the webinars and this kind of thing. So thank you very much for joining us, and hopefully we'll all see each other again for the next webinar in August. Thanks very much.